Assalamualaikum. Boleh start ke?
Waalaikumsalam. Boleh.
Okay.
Sekejap Okay. Assalamualaikum warahmatullahi wabarakatuh. Welcome everyone. So we'll begin our session today with Kitab Al-Fatihah. Okay. Assalamualaikum everyone. Welcome to case-based seminar 3 supervised by Dr. Alwi. So there'll be 4 presenters for today, presenting 4 different cases. Okay. So this will be the cases that we'll be presenting today. We'll have a child who has altered sensorium, abnormal gait, lower limb weakness, and child who has diarrhea. So let's start with the first one, which is child who has altered sensorium. My name is Afrina. So imagine, so as if communicating with young children with normal sensorium, normal mental state is challenging enough. So you would imagine gaining information from a child who has altered sensorium. So I'll start my presentation with a case summary found so this is found in a letter called ED legal letter, in which they review and compile a lot of medical legal issues in the ED. So this is this letter, this version was titled AMS in Children, Finding Diagnostic Clarity When the Clinical Presentation is Murky. So they compile a lot of cases in this particular letter concerning AMS in children, altered mental state. So one of the case is a 5-month-old girl presented to ED with vomiting, high-grade fever, lethargy, and extreme irritability. So this patient came to ED with these symptoms. And then further history, she had multiple episodes of otitis media, but currently on current presentation to the ED, her ears were normal on physical examination. It was just that she had previous episodes of otitis media. Also, her white blood cell count was significantly raised as well. So in view of her symptoms, she was given paracetamol, and then eventually upon monitoring, she was then discharged from ED since her temperature has been reduced. So she was not even treated inpatient. So at home, the parents complained that the fever still persisted and the patient is still irritable. So instead of going to the same hospital, the parents sought medical attention with their own pediatrician, in which was advised to send back to ED for lumbar puncture for CSF analysis, in which when CSF analysis was done, it revealed that the girl had actually had bacterial meningitis. So this girl, so this took quite some time again, and this girl was discharged from ED without even considering inpatient. And then eventually they found out that this girl has bacterial meningitis. And then eventually the child was actually impaired permanently from the alleged delay in diagnosis and treatment of meningitis. So because of this, this led to the parents going for litigation, so taking legal action because of medical negligence. So from this case itself, you would imagine just a girl with a 5-month-old going with vomiting, fever, lethargy, and extreme irritability. And this because of negligence, because of not investigating further, she had a delay in diagnosis and treatment, so leading to permanently impaired. I was not sure what exactly was the impairment, but she was severely affected by this delay. So that is just to show how severe, how important this particular presentation is. Okay, so in terms of altered sensorium, so altered sensorium is a condition of being less responsive to and aware of the environmental stimuli. Okay, so in terms of altered sensorium, it could be the range of spectrum is very wide. It could be as simple as child agitation, child is agitated, or it could be as severe as coma. So these are some definitions that are related to the term altered sensorium. So for instance, coma, which means unarousable unresponsiveness, and also unresponsive to pain. Stupor, which means they are only responsive to pain. Hypersomnia and pathologic drowsiness, so increased sleeping. So, but they are still responsive to pain and other stimuli. Delirium, which is described as clouding of consciousness or confused state. Syncope, which is a brief loss of consciousness. So these are some of the terms that are closely associated with the term altered sensorium or altered mental state. And then, okay, so we'll go to the potential causes for altered sensorium. So we can divide them into structural causes and non-structural causes. So structural causes, of course, head trauma, trauma to the head, which could possibly be intracranial bleeding, cerebral edema, or shaken baby syndrome. Other structural causes could be tumor, stroke, hydrocephalus. In terms of non-structural causes, we should also, just as the case just now, infection, toxin and drugs are possible cause as well. Interception, metabolic derangement, as well as seizure. So these are some of the causes relating to altered sensorium. Okay, so another case scenario. So a 2-year-old girl presented with increased sleepiness for 2 days. So it was associated with symptoms of irritability, aggression, weakness, and refusal to walk. And there was also reduced oral intake and urine output. Otherwise, there was no fever, no cough, runny nose, vomiting, diarrhea, rashes, seizure, or recent head trauma, no recent sick contact or travel history, and family reported no medications at home. So this is the case scenario. So what are the further history that we want to know? So in terms of history taking, we need to know the onset of the altered consciousness, whether it's sudden or gradual. So sudden, we would think of something more traumatic, more acute, such as intracranial hemorrhage, an episode of epilepsy, seizure, trauma, basically trauma. So gradual, we would think of things like infection, metabolic derangement, and space occupying lesion, which could be the potential causes. Other associated symptoms that we need to know further, fever for possible infection, seizure, rashes, headache, neck stiffness, photophobia. We would want to rule out for meningitis, vomiting, blurred vision, ruling out for raised intracranial pressure. Okay, and then any underlying medical illness, just epilepsy or diabetes mellitus, any family history of malignancy or consanguinity, in which we would think of inborn error metabolism. Okay, so continuing the case scenario, so the girl was afebrile with pulse rate of 125 beats per minute and respiratory rate of 21 breaths per minute. Blood pressure was normotensive and SpO2 was 100% in room air. On examination, she seemed sleepy and difficult to arouse. Otherwise, other neurological examination and other systemic examination were unremarkable. Full blood count, serum glucose, urine toxicology, screening, CT brain, and CSF analysis were done, to which all revealed normal and unremarkable results. So we would think of what are the potential cause for this particular case. So going to physical examination and investigation. So on physical examination, we would like to see the general appearance of the child, whether child is toxic looking, whether there's evidence of trauma, especially to the head. So the head, look whether it was disproportionately large, bulging fontanelle, ruling out raised ICP. Eyes, look for unequal pupils, papilla edema, retinal hemorrhage. Breath, whether there's ketone odor, ruling out diabetic ketoacidosis. Neurological examinations such as Koenig's and Brzezinski's signs, if positive, which could suggestive of meningitis, and then look at the vital signs. So that is for physical examination. In terms of investigations, could do full blood count, look for any raise of white blood cell, leukocytosis, capillary blood glucose, especially you want to look at whether the patient is hypoglycemic, and then blood gases to look for metabolic derangement, serum ammonia, especially if hyperammonia could suggest hepatic encephalopathy or inborn error metabolism. Lumbar puncture for CSF analysis if there is suspicion for meningitis, and CT brain if there is suspicion, if there is history of trauma and signs of increased ICP. So those are physical examination and investigation. Some important physical examination and investigation that we would like to elicit, we have to perform. Okay, so continuing the case scenario just now. So upon further inquiries, it was discovered that actually several medications previously not reported by the family were present at home, including an atypical antipsychotic aripiprazole. So the medication was actually prescribed to the patient's older sister and often left out on the kitchen counter, and was assumed that it was out of her reach, out of the patient's reach. And then drug levels were sent for the medication, and the patient was actually found to have aripiprazole level of 609 ng per ml, in which for reference, the therapeutic level in adults is actually 150 to 210. So this is actually a case of intoxication, accidental intoxication. So that is for the case scenario. In terms of management for patients with altered sensorium or altered mental state, this is based on PEAKS protocol. 4 main things. So this is a very crowded slide, but just 4 main things, 4 main titles: initial assessment, the GCS, and then whether there's consideration for endotracheal intubation, and look for and treat these 4 particular things. So for initial assessment, A, B, C, D, but the D is dextrosticks, for glucose. So airway, secure the airway, look for any obstruction. Breathing, check the oxygen, see whether there's a need for artificial ventilation. Circulation, whether there's need for IV fluid resuscitation. Then D in this case is dextrosticks, glucose basically, to correct if the patient is hypoglycemic. And then the second one is GCS. So if patient's GCS is 12 and above, should monitor the GCS per hour, every hourly. But if the GCS is lower than 12, the GCS should be monitored every 30 minutes until the GCS is improved. So there are also situations where endotracheal intubation should be considered, such as if the airway will obstruct, if not supported, if airway is compromised by vomiting, the respiratory rate is too low for adequate ventilation, SpO2 remains less than 92% despite intervention with high flow oxygen and airway opening maneuvers. And then if there is signs of shock, even after resuscitation with 40 mils per kilogram of fluid, signs of exhaustion, as well as GCS of less than 8 and deteriorating. So these are some scenarios or situations where endotracheal intubation should be considered in this patient. And then as well as the 4th one is to look for and treat for raised ICP, sepsis, shock, and seizures. So that is for the management. This is just to lay out the GCS to compare the pediatric GCS and adult GCS, but both are total up to 15. The only difference is mainly at the verbal response. And this is just some famous mnemonics actually on Google, the AEIOU tips or move stupid, which actually are just mnemonics to remember the causes of altered mental status. Okay, so I think that is all for my part of the presentation.
Okay, good. Any questions? If no, I think we can just proceed. If you got any questions, you can just stop the presenter and ask. And then we will talk about, we conclude at the end. Okay.
Assalamualaikum warahmatullahi wabarakatuh. I'll continue on the next topic, which is child with abnormal gait. My name is Nurlaini Azifa. Okay, I'll be quick. So before we say or we diagnose the children as having abnormal gait, we need to know first the normal gait. So in children, it based on the age of the children. So as you can see here, from 8 to 15 months, this is the age that where the children start to walk, and usually the children will have a broad-based gait for support. The stepping is high step, and patient will have flat-footed. The arms will be outstretched for balance, and the legs are sometimes externally rotated with a degree of bowing. So in this age class, if patient have bowing or flat-footed, you should not be worried yet lah. So next age is 15 to 18 months. This is the time where the heel strike started to develop. So you can see the foot is no longer flat, and there is increased stride and velocity, and also the arms also is no longer outstretched. Instead, it becomes reciprocal. So like it's moving with the walking. Next. Okay, so in 2 years old, basically at this age, the broad-based gait has already diminished, and patient is able to, the kid is able to run and change direction, like in this picture. They can already change direction, and by the age of 7 or 8 years old, at this point, the children will eventually have like adult-like pattern of walking. Okay. So that is the normal gait for the pediatric patient. And the abnormal, okay, next, abnormal gait, there are basically a few types of abnormal gait. First, the antalgic gait. This is usually because of the pain. So the kids will try to reduce the time spent weight bearing on the affected side. So if the pain is on the left side, patient will try to use the right side to walk. And as you can see, the gait will become like macam tu lah. So the causes can be due to trauma, spinal osteomyelitis, or can also be due to JIA, juvenile idiopathic arthritis. And another one is circumduction, where there is excessive hip abduction as the leg swing forwards. And this can be due to leg length discrepancy, where the length of the leg is not the same. Can also be due to JIA, where there is stiff or restricted joint movement of the head, and also can happen in cerebral palsy, unilateral spasticity, where there's only one leg affected. Okay, another type of abnormal gait. Okay, next. Is the spastic, where there is stiff and foot dragging with foot inversion. So you can see the foot is usually stiff, and this commonly occur in same in cerebral palsy, diplegic or quadriplegic cerebral palsy. And ataxic is when there is instability of the gait. The patient cannot you have both lah, narrow and wide base. Like so, patient will be unstable. So this occur in ataxic cerebral palsy, cerebral ataxia, Friedreich ataxia. These all are due to the instability. Okay, next, thank you. The abnormal gait is the Trendelenburg gait. I'm sure you all know this because of the muscle weakness, where if you stand on let's say the right leg is the weakness is on the right leg, and if you stand on the right leg, the left leg will drop down. You can see if you do the Trendelenburg test. This commonly occur in leg calf pertest disease, where there is avascular necrosis of the femoral head, or in slip capital femoral epiphysis, where the epiphysis to dislocated. Developmental dysplasia of the hip, DDH, GIA, again, same thing, and neurologic condition like spina bifida or cerebral palsy. Okay, there is some more. Next. Toe walking can usually be normal in some patient. But if it is persist, then you need to think of other things like persist up to age 3 years old. Like you need to think of again cerebral palsy or mild lysosomal storage disorder. And then another thing is stepping, when patient try to lift the entire leg at the hip to assist the with the walking. This happen because patient have weak ankle dorsiflex, so it cannot dorsiflex the ankle, and to try compensate that, they will increase the knee flexion. So you can see as in the picture. So this happen usually in spina bifida patient, polio patient, or in Charcot-Marie tooth disease, things like that. Okay, next. I think the last one. The last one is the clumsy gait. This occur when there is difficulty in motor coordination, like the fine and gross motor cannot be synchronized. So patient usually will come with gross motor, frequent falling, and fine motor like unable to button shirt, poor handwriting. So this usually happens in cerebral palsy, cerebral ataxia, metabolic disorder. Okay. So next, that is the abnormal gait. So we move on to our case. Case scenario. A 4-year-old girl was noted by her parents to be limping intermittently for several weeks. So this is our chief complaint. And the causes, you can see, as you can see, okay, next. The causes are divided into the age group 1 to 3 years old, 3 to 10, and 11 to 16 years old. And you can also divide into acute and chronic. Acute usually will come with painful limb, and chronic they can have like painful, but it can also be painless now. Okay, so usually acute is commonly caused by infection like septic arthritis, osteomyelitis, or trauma like accidental or non-accidental trauma, malignant disease like leukemia and things like that. And chronic and intermittent, you can see like some of the diagnosis is it can occur in not just one age group lah. Like GIA can occur in 1 to 3 years old, but it can also happen to 3 to 10 years old of age. So you need to like consider all these diagnoses while with patient coming with limb. Okay, so for our patient is 4 years old, chronic for several weeks. So we are thinking of Perthes disease or Duchenne muscular dystrophy, GIA, and tarsal coalition. So in approaching patient with chronic limb, okay, next, the history. Also, this is just another differential diagnosis for 11 to 16 years old that you can see that. Okay, next. The history, okay, so history first to confirm the age, as we divided the diagnosis into the age group, and then the limb, because patient complain of, not patient lah, parents complain of limping. So limping can be due to 3 causes, either because of the pain, because of the weakness of the muscle, or the lower limb, or because of structural or mechanical abnormalities of either the lower limb, spine, pelvis, or the leg. So you have to confirm this with the any patient which one of this is does cause him to be limping? Is it because of pain? So if pain, you can thinking of trauma or infection. For structural, you can think of leg length discrepancy. And if pain, so like usual, you use the Socrates, the site, ask the patient exactly where is the site of the pain, whether it's at the hip or knee, as those can give different diagnosis, and whether it is unilateral or bilateral. And also don't forget to ask if it is at the joint, ask other joint like in the upper limb joint. And then the onset, acute versus chronic, or is it like gradual onset, insidious onset, worsening over time? The characteristic of the pain not usually have much difference. Radiation, like I mentioned, pain at any other sites of the joint in the upper limb. Associated symptoms, gelling, like the stiffness after long period of rest, like in GIA patient, morning joint stiffness, fever, joint swelling. So with fever and joint swelling, we are thinking of infection, but joint swelling can also be in GIA patient. Backache, and don't forget to ask for red flag symptoms. We are trying to rule out malignancy like weight loss, any night pain. And then the time, is it insidious or persistent, or is it intermittent? Exacerbating factors or relieving factors. Do patient needs painkiller to alleviate the symptoms, or does the pain improve with movement, or worsening with movement? And the severity, limitation of daily activity. Can patient still be went to school, or they are less inactive because of the pain? And then for the red flags, as I mentioned, we need to rule out the malignancy. And if there is any inconsistent history and incongruent injuries, meaning we need to think of child abuse juga, because it can cause fracture. So think of child abuse, and then history of trauma or fall from the patient or from the parents. Okay, next, that is for the history. And the other history, just as usual, when you are doing the history, past medical history, medication history, current medication, any drug allergy, perinatal history, developmental history is important. If there is delay in walking or persistent to walking, like I mentioned, to walking can be normal, but if persistent, then it need to be investigated. Or regression. Regression meaning instead of can dulu boleh jalan, sekarang tak boleh jalan. Regression. Family history with the same symptoms, or family history of malignancy, we need to rule out malignancy. And then social history, also do systemic review, because like in SLE, for example, GIA can come with rash or uveitis in GIA, so you need to do the systemic review. Okay, next. Okay, so continue with our patient tadi. Her teacher at school commented that she was quieter, less keen to play, and was not able to sit on the floor in story time. So in patient, usually patient with younger age group 4 years old, they will not complain of pain, but their daily activity is interrupted, or they don't want to do any activity because of the pain. So you should suspect things like that in patient yang less active. Okay, so next. For the physical examination, you start with general, well or ill-looking patient, any dysmorphic features, body position, or do the vital signs, and then ask the patient to what type of gait. This will be assessed in PGAL's assessment. You have the gait, limb and spine assessment. And then anthropometric measurement, see if there's any short stature. You have to take the weight and BMI of the patient. So for the musculoskeletal examination, first look if there is any abnormalities, any scar, any rashes, if the joint is in either like fixed flexion or fixed extension, and then feel of all the joints, if there is any increased temperature or there is any swollen, you would think of things like infection, and then move the joint if there is any limited range of motion, and then do neurology examination, developmental milestones and other symptoms to rule out the systemic causes that can cause limping. Okay, PICALS too, I did put it in the, okay, next we do. Okay, later we look at the PICALS. So for the case scenario, the patient, the general practitioner, performed a PICALS assessment and observed she had a limp and her right knee was wounded and restricted. Okay. Next we do the investigation. So 3 investigation: blood test, imaging, and specific tests. Okay, so at this point you already kind of can guess the diagnosis of the patient, so you do the investigation to either rule in or rule out your diagnosis lah. Okay, so for blood test, we do full blood count to look for any elevated white blood cell, look for any infection and inflammatory markers. Same to rule out any infection. Imaging, ultrasound of the affected limb. So if our patient is the knee, so ultrasound of both bilateral knee, so we can compare which one is normal, which one is not normal. That one is actually ultrasound of the joint. And then we can do CT scan or MRI if we are thinking of malignancy. We want to rule out malignancy, and specific tests like slit lamp examination in GIA patient, ANA, and also rheumatoid factor tests. So in this patient, next. So investigation showed that her basic blood test, the full blood count, the acute phase reactants were normal, but her ANA test was positive, and she also had evidence of chronic uveitis on slit lamp examination, although she had no usual symptoms. So diagnosis at this point is juvenile idiopathic arthritis. So next, to manage this patient. So this patient, for the limb, she was given corticosteroid injection of the knee, and then she went physiotherapy, and also the pediatric rheumatology multidisciplinary team also provide the parents with the information and support, and she will need follow-up if there is flares in the future. And for the uveitis, she was given topical corticosteroid. So usually the management depends on case basis. In this patient, GIA, so it was managed as GIA lah. But for patient with, let's say, like septic arthritis, so then you need to manage patient according to the diagnosis. So I think next is the management, management of GIA from the PITS protocol. So with oligoarthritis, like in this patient, just one knee is affected. You start NSAIDs, review in 4 to 6 weeks. If it is improving, you can continue NSAIDs and review in another 3 weeks. If it is persistent, then you may give the intraarticular corticosteroid that this patient received, and then review and we may need to start disease modifying anti-rheumatic drugs. That this is the for the patient with no improvement, after no improvement. Okay, so later you can go on of this treatment. And then next is the PCOS examination. So this is the screening tools for musculoskeletal disorder in pediatric case. So you start with a screening question. Do you have any pain or stiffness in your muscle, joints or back? Any difficulty getting yourself dressed without any help? This is to assess the fine motor. Any problems going up and down the stairs, and then you do the inspection, the gait, the arms, legs, and spine, and so on. So you can go through this later. So yeah, I think that's all for me. If you have any question, later you can ask.
Okay, so I'll continue with the third part of the presentation. This is the child who has a lower limb weakness. Next. Okay, as our introduction, so those who have lower limb weakness, we have two definitions: weakness or hypotonia. As for weakness, they are the decreased ability to voluntarily and actively move the muscles, and for hypotonia is a low muscle resistance to movement. So we can differentiate this but by using the neuro examination. Because weakness, we use the test for power and hypotonia for the tone. So it can come individually. However, they usually come both together, weakness and hypotonia. For this weakness and hypotonia, they can come from any lesion from the upper motor neuron, lower motor neuron, neuromuscular junction, skeletal muscle, or systemic diseases. So it's a wide spectrum of the disease. Okay, next. So the causes of the lower limb weakness is a wide spectrum from the brain to the muscles. So it can be divided into two: upper motor neural lesion or lower motor neural lesion. For the upper motor neural lesion, they include the brain and the spinal cord. As for the spinal cord, all the structure of the spinal cord except for the anterior horn cells. For the lower motor neural lesion, it starts from the
You can.
As for the lower motor neural lesion, it starts from the anterior horn cells down to the muscles. So for the brain, the causes may include the brain tumors, infection, for example, like meningitis, encephalitis, or an infection. As for the spinal cord, they include the acute transverse myelitis, any tumors or an infection. As for the lower motor neural lesion, for the anterior horn cells, it includes the poliomyelitis. However, polio has been eradicated in Malaysia, and Malaysia has declared Malaysia as a polio-free country since the year of 2000. As for peripheral nerves, it includes the unilateral or bilateral. For the unilateral, will include the enteroviral infection. For bilateral, the GBS, which is Guillain-Barré syndrome. And for neuromuscular junction, include the myasthenia gravis, thick paralysis, or botulism. As for the muscles, include the myositis or DMD, the muscular dystrophy, Duchenne muscular dystrophy syndrome. Next. For the HPI, so we have a patient presented with lower limb weakness. So what question we want to ask the patient? First, we need to assess the lower limb weakness. As the onset of the weakness, the duration when it started, and the progression, how it progressed from it started until today, the day of the admission. And then check the limb weakness, either it's symmetrical or asymmetrical. And then location of the weakness, either it's only at the proximal or at the distal, or is generalized, proximal and distal. And then ascending or descending for the progression. For example, in GBS, it usually ascending weakness started from the distal going up. And then progression and severity, previous episode of weakness, worsening and relieving factors. Is there anything that worsen the weakness? And then does it associated with any pain, paresthesia, or numbness? And ask for any history of infection, for example, like GBS. it usually preceded by infection. And then if we suspect it, from the spinal, it may have a bladder or bowel function or back pain. It also may cause like bulbar involvement, which include the difficulty in swallowing, weak jaw, facial muscle, weak jaw and facial muscles, progressive loss of speech, facial paralysis, oculomotor involvement, for example, like diplopia or ptosis, and sometimes they may present with a respiratory failure. Include the difficulty in breathing and sinuses. Next. For other history, we also need to rule out other causes because lower limb weakness include many causes. So does the patient ingest any toxin or any toxic substances prior to the weakness, because you want to rule out any toxic myopathy. And then ingestion of a spoiled preserved canned food because they may have the botulinum toxin, they may cause botulism. Also, sometimes botulinum toxin may also have in honey. The honey. And then immunization, either the immunization up to date, up to the patient age, because we want to rule out any poliomyelitis. And then family history, is there any autoimmune disease, hereditary neuromuscular disease. And then birth history, preterm delivery, maternal infection, any complication during the labor. And then developmental history, any delayed motor milestone, any speech or language delay. This is to rule out any brain pathology. Next. So for physical examination, generally we assess the patient. Does the patient alert and conscious? Is there any respiratory distress? Syndromic facies, for example, like Down syndrome, Prader-Willi syndrome. Prader-Willi syndrome, usually they presented obese patient with hyperphagia. Then I can read about Prader-Willi syndrome. But then check for the surrounding. Is there any wheelchair, walking stick, which may indicate that patient have difficulty in walking? And then check for the inspection. For inspection, check for the muscle bulk. Is there any muscle wasting, pseudohypertrophy, muscle wasting or muscle atrophy? We may want to differentiate between the upper and lower motor neural lesion. And then presence of angosh tick, which may could tick paralysis, because tick sometimes they release a toxin, they may cause a paralysis. And then fasciculation, which occur in the lower motor neural lesion. And then lower limb examination, which is TPR, tone, power, and reflex. For tone, check for hypotonia, which is usually hypo or hyper. This is to differentiate also the upper or motor neural lesion. Check for the power and reflex, and Babinski reflex. And then sensory, if there is a reduced in sensory, we need to determine either the sensory, it's based on dermatomal, or is a Glyphosatokin, because to differentiate between either is a periphery or the spinal causes. And then cranial examination, this is the gait, and then meningeal sign, Koenig's and Brzezinski sign, cerebral examination for any ataxia, and anal tone for any spinal lesion. Next. So this is just a picture of Koenig and Brzezinski. Koenig sign is knee extension is painful. Brzezinski sign, when neck flexion leads to knee flexion. And then Gower sign, this is how the patient usually standing up. Okay, you can see the picture. Okay, next. For the differentiate with the upper motor neural lesion and lower motor neural lesion, here are the table. Usually, but how I remember it, that upper motor neural lesion will no or minimum atrophy with hypertonia and hyperreflexa with no fasciculation. For lower motor neural lesion, usually there's atrophy, hypotonia, hyperreflexa with fasciculation. And then for more detail, you can read the table. Next. For the investigation, I divided into laboratory study, imaging study, and others. For laboratory study, for full blood count, to look for any increase in white cell as indication for infection. Serum creatine kinase, which is really elevated in inflammatory myopathy, for example, like viral myositis, polymyositis, or Duchenne muscular dystrophy. And then serum electrolytes to rule out any metabolic myopathy, for example, the lower limb weakness due to hypokalemia or hypocalcemia. Then labor puncture to rule out any infection, meningitis, encephalitis. Imaging studies, we do MRI spine with contrast to rule out spinal pathologies, and others include the nerve conduction studies and electromyograph. Next. So this is management. Management for each type of the disease, it a lot. So you can read it by yourself. However, we need the first thing we need to manage the patient, always manage the ABC first, airway, breathing, and circulation. And then we can go to the specific management for each type of the disease once we get the diagnosis. Next. So this is the algorithm from the PITS protocol for acute flaccid paralysis. You can go through this table later. And then if patient presented with acute flaccid paralysis less than 4 days, those at the age of less than 15, we need to report them. So there's a protocol for this because we want to make sure that the acute flaccid paralysis is not from due to polio. So we need to send samples to make sure that it's not from polio. Okay, next. I think that's it for me. This is my reference.
Okay. Yeah. So I'll continue on the presentation with a child who has diarrhea. Okay, next. So this complaint is a 2-year-old boy with no non-medical illness presented with complaint of loose stool for 1 day duration. Okay, next. So before we move further, let's first revise the definition of diarrhea, which is the passage of 3 or more loose or watery stool per day, or more frequent as compared to normal for the individual. And acute diarrhea is abrupt in onset of 3 or more loose stool per day and lasting less than 14 days, while chronic or also known as persistent diarrhea, which begins acutely and then persists for 14 or more days. Okay, next. So for the diarrhea, you have a variety of differential diagnoses, which are divided according to their age. So for acute diarrhea, gastroenteritis is common, and then you can also have a systemic infection. In older children, you can have food poisoning, and it can also be overfeeding in infants. While in chronic diarrhea, it's you can have allergic to the food, such as milk protein or excessive fruit juice ingestion. In children, you can also have lactose intolerance, diarrhea, IBS, IBD, and also parasitic infection. Okay, next. So for history taking of diarrhea, especially this is for acute diarrhea, in which you will have to ask more of the onset of the diarrhea, the number of episodes per day, the amount for each of the episode, and then if there is blood or mucus in the stool, and then the normal bowel habit of the children, and also if this is the first presentation of, or if there's any recurrence. And then you would have to ask the question like any recent history of eating outside food, especially in food poisoning, and then recent change of the formula milk, any sick contact in family with similar symptoms in food poisoning, and also a recent travel history. And then for associated symptoms, you have to ask if there is any vomiting, and then ask further on content, the amount, and also the episode of the vomiting. And then if there is any fever, if they're low grade or high grade, and if the patient is from a dengue prone area, any antibiotic history, and also if there is a infestation of rodents in the or pets at home, which could be infection cause of fever. And then the abdominal distension, and also ask further on the reduced oral intake. And you have to compare before and also the current presentation, and also the hydration status of the child, whether the child is less active, if there is sunken eye, if noted by the mother, and then if there is a reduce in the urine output. You have to ask how many times they change the pampers in infants, and then if there is any weight loss or rashes noted by the mother. And then next. So apart from that, other further history you will have to ask is the past medical history if the patient is immunocompromised, and then the drug history if there is any recent medication, and also any allergy or rash, and then immunization history if it's up to the schedule or not, or if there is any other additional vaccine, and the nutrition history, the normal intake of the child, and if there is any recent ingestion of formula milk, large ingestion of formula milk or fruit juice, and also the milk bottle hygiene. And then family history, family members with similar complaint, and a social history, the water source, if there is the water source is contaminated, and then the whether this child is from orphanage, because that points more towards infective causes of diarrhea. Okay, nice. For physical examination, your aim is to assess the hydration level of the child. So you have to look if there, for the general examination, check if the child is less active, irritable, can the child drink, any sunken eye, dry membrane, or clotted tongue, and then you assess the skin turgor. And then, and also the vital signs, if there is any weak pulses, tachycardia or tachypnea, the blood pressure, and also the temperature. And then for abdominal examination, for any tenderness, any distension, and also the skin turgor. Okay, next. So this table is to show you the severity of dehydration, which are divided into mild, moderate, and severe. You will have to do this as you do the history taking and also the physical examination. You look at the general appearance of the child, the eyes, whether it's sunken or not sunken, if the child's cry, if there's any tears present or absent tears, is the child can drink normally or drink eagerly or does not drink, not able to drink, and then the mucous membrane and also the urine output, whether decreased or normal. And then for infants, the fontanelle, sunken fontanelle in very severe hydration, and then CRT, peripheral pulse is weak in severe dehydration, and then the heart rate and breathing, which is tachycardia and tachypneic in moderate to severe, and then blood pressure and skin turgor. Okay, next. So for chronic diarrhea, apart from what have been presented before, we can also ask whether the onset is congenital onset or abrupt onset is more of infection, or with introduction of the weak cereals, which points more towards celiac disease. And if there is any etiological clues like blood in the stool, which could point to IBD, and also if the stool is light or tan color, which points toward the celiac disease. And then if there is any associated symptoms like abdominal pain in cases of IBD or irritable bowel syndrome, IBS, or chronic intestinal obstruction. And then if there's excessive flatulence in carbohydrate malnutrition, and also any loss of weight or failure to thrive. Okay, and then you would also have to assess the complication, especially in malnutrition because of chronic diarrhea. If the patient is lethargy, dry skin or brittle hair, and also the hydration status. And then the past medical history, if they have underlying hypothyroidism or IBD or immunocompromise. And then if patient have undergone any therapeutic intervention like drugs or any drugs, any recent surgery or any antibiotics started. And then family history and also the social history as mentioned before. Okay, next. For physical examination of chronic diarrhea, is also apart from the assessment of hydration, you will also have to look for any evidence of malnutrition, look at the muscle bulk and also the subcutaneous fat, and any evidence of nutritional deficiency, and also any evidence of extra-intestinal signs, especially if you are thinking of IBD. And then it's also important to look for growth chart, and also if there is any failure to thrive, and also to stage the pubertal stage of the child if it's an adolescent child. And then for the vital signs, for any derangement, and also the abdominal examination, as mentioned before. Okay, next. So now we move on to investigation. For investigation, it could be divided into blood, stool, and also imaging. So blood investigation, you could do full blood count to check for any anemia or leukocytosis infection, or even thrombocytosis in IBD. And then renal profile, they can have high serum urea and creatinine in dehydration in patient with dehydration or patient with acute kidney injury. And then liver function test for hypoalbuminemia in malnutrition patient. And then inflammatory markers, ASR and CRP could be raised in IBD. And then ABG is considered if the patient is having shock. And then random blood sugar if the patient is poor oral intake. Okay. And then for stool investigation, stool microscopic investigation, for you to see if there is blood or leukocytes, which points towards colitis secondary to Shigella, Salmonella, or E. coli. And also stool culture and sensitivity in cases of bloody diarrhea or watery stool or immunocompromised children, for you to identify the causative agent, and also stool over NCs to identify causative agent. Stool pH, electrolyte, and osmolarity could be considered if you want to differentiate the osmotic and secretory diarrhea. Osmotic is pH is less than 6, and secretory is pH is more than 6. Fetal calprotectin is for IBD, which will be raised in IBD. Okay, next. For imaging investigation, you could opt for CT scan of the abdomen if there is any small bowel involvement or stricture in cases of IBD usually, and also in contrast study if you want to look for any congenital malformation or motility disorder. Otherwise, you could also consider colonoscopy or biopsy in inflammatory bowel disease, for you to take biopsy for histology. Okay, next. So that's for investigation. For management of acute diarrhea, before you do anything, you have to assess whether the patient is having mild dehydration, moderate dehydration, or severe dehydration. And then you follow the plan, the plan A, plan B, or plan C. And then, however, the principle of management is for you to you have to give extra fluid. You have to advise the patient to breastfeed the child longer, more frequent, more longer. And if needed, you could give them oral rehydration solution or IV fluid therapy if indicated. And then continue feeding, and you also have to educate the mother on when for them to return to hospital, with whether the child start to drink poorly or cannot drink or breastfeed, or the child becomes sicker, the child develops fever, or there is blood in stool. Pharmacological agents is more of towards AGE. If antimicrobials is more towards if you have suspecting of bloody diarrhea or shigellosis. And then antidiarrheal agent is as an adjunct for AGE treatment. The agent is a diosmectide, in which it will restore the integrity of the damaged intestinal epithelium. And then the zinc supplement is recommended by WHO in a prevalence of zinc deficiency population. Okay, next. And then for chronic diarrhea, you will have to assess the resuscitation. Principle is initial resuscitation with IV fluid, correct the abnormalities, hypoglycemia, and also prevent hypothermia, and also treat underlying cause. And then at the same time, you have to look for the nutritional assessment and rehab. If the patient is having micronutrient deficiency, then you supplement it like iron supplement, vitamin A supplement. And then if patient is having lactose intolerance, then you continue breastfeeding and also change to lactose-free formula milk. And also in patient with severe weight loss or prolonged IV hydration, then you have to be aware of free feeding syndrome. So you will have to take the serial monitoring of electrolyte for you to monitor the patient. Okay. So that's it for me.
Is that all? 4.
Yes, doctor.
Okay. So any questions? So we start out with altered behavior, and then limb gait abnormality, lower limb weakness, kan? And diarrhea. So any questions? Okay, presenter number 1. Give 1 or 2 take-home message from your presentation.
The range of spectrum for altered sensorium could be as mild as irritability of the child to more severe, such as coma. So yeah, need to look up for this presentation.
Okay. My take-home message for this, for altered sensorium or altered behavior, is number 1, always remember D in your assessment. Always remember D in your assessment. It's always A, B, C, D. Okay. And don't take for granted the first stage of altered sensorium, which is irritability. Some of us, when we see children, I mean, with irritable children, what we say is, oh, this is a non-cooperative child or anxious child. But remember, you have to investigate thoroughly, patient, especially with altered sensorium. When a mother came to you complaining of a child being lethargic or less active or being inconsolable cry, okay, you have to do a detailed examination. And one of the most important examination that you have to do is look at the pupil. Okay, look at the pupil. It's very important. Okay, look at the pupil. Check the glucose, look at the pupil, and also that's the least lah you have to do. And kalau you malas sangat kan, atau tak sempat sangat, do reflex, check for reflex. Check for reflex and tone. Okay. Don't miss lah, don't miss. Okay, I just had one mortality on Monday, last Monday. The child started out with altered behavior. Okay. And actually, the symptoms of altered behavior has started at 8 a.m., 8 p.m. The father claimed that the child started to show had become sleepiness, more sleepiness, lethargic from 8 p.m. And then at 10 p.m. become confused, delirious. And then there's a very typical spectrum lah. Started out with lethargic, sleepy, and then become within 2 hours become delirious, irritable, and then finally at about 12 p.m. becoming more obtunded and finally comatose. 1 a.m. I intubate the child. So in the 5 hours, I mean he went through all the spectrum, all the progression of altered behavior till the end of comatose in 5 hours. And I was only being informed when his level of consciousness is around confused, which is it's already at the middle. And between confused to obtunded to comatose, it takes only a matter of hour or minutes. If in a child with progressive illness, especially because it's usually this is a sign of cerebral edema of any causes. And you need to know there's 4 types of cerebral edema. Can be vasogenic, cytogenic, could be osmolarity, osmotic, or it could be actually what you call it, cytogenic, vasogenic, osmotic, or interstitial. So anything can cause this, and you have to be alert. Okay. Number 2. One presenter number 2. Take a message.
Yeah. So for my part, I think first is what apa ni? Macam the normal gait tu, don't the abnormal gait, don't dismiss it before you investigate the causes lah. The common causes is common, tapi the rare causes like malignancy tu you need to investigate that too. And then if patient come with abnormal gait, look closely the types of gait, and you can get a lot of things from the history and physical examination only, because some of the investigation is not so specific for the abnormal kidney. So you must really rely on your history and physical examination.
Good, good. Okay, abnormal gait. Rarely, acute condition cause abnormal gait. Rather, acute condition, they usually start out with lower limb weakness, and then after that, they become abnormal gait. But the take-home message from my part is, you have to be able to identify what gait is it. Okay, this is good for your exam and also definitely for your clinical. If you know what type of gait, then you know how to manage and where to refer. Okay, in general, patient with antalgic gait is almost always orthopedic. Okay, rarely, for example, you've mentioned JIA kan. JIA, they don't present with antalgic gait so much, because usually it's involved like small muscle, a small joint, even large joint point is rarely cause so severe until it cause antalgic gait. Okay, and then for example, other like circumducting gait or hemiplegic gait is very typical of upper motor neuron sign, usually stroke or hemiplegia, CP. So that's all lah. Okay, number 3.
Okay, so for my part, I think it's very important to differentiate what the cause of the lower limb weakness, because lower limb weakness can be from the brain down to the muscle itself. So we need to identify each characteristic for the disease and identify what are the causes of the lower limb weakness in the patient. I think that's it for me.
Very good. Okay, for my part, I think lower limb weakness, you have to think of acute flaccid paralysis. Okay, because one of the main indicator for a developed country is the absence of polio. Okay, we are doing polio eradication strategy throughout the world, and we've been polio eradicated. However, it can reflect the lack of monitoring, or it can reflect a true low prevalence. Therefore, you always need to have a high degree of suspicion of polio or any other cause of flaccid paralysis in a child who presented with acute lower limb weakness. Okay, remember, so if you become a doctor later, houseman, KMO, any child who came with lower limb weakness, make sure you take stool sample. Okay, you have to take stool sample. It's your responsibility. Okay, you don't want to miss polio, or you don't want to miss any acute flaccid paralysis, any cause of acute flaccid paralysis, because if you don't treat properly, they may end up incontinence and also paralyzed lah, paraplegia forever. Okay, last one.
For diarrhea, I think it's important for you to treat it properly and also classify it properly if it's mild, moderate, and severe, because definitely severe dehydration, you cannot treat at home.
Okay. Good. Of course, doctors, any doctors, regardless UGP ke, FMS ke, KKMO or any MOs, assessment of dehydration is very important, and it's a compulsory for you to know. Regardless lah your surgeon ke tak. We know some surgeon, they have some problem with assessment of dehydration, but anyone who died because of dehydration is a true fault lah on clinician side. Okay, I think that's all. Ada one last question ke? Kalau tak ada, then we can stop. Okay, that's it. So we can postpone dengan tasbih kafar. Bismillah. Okay, Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam. Thank you, Doctor.
Thank you, Doctor.
Thank you, Doctor.
Thank you, Doctor.
Thank you, Doctor. Oh, belum, Nam?
Thank you.